Hello everyone. Let us now discuss fluid and electrolyte disturbances. In this part 1 module, I shall be talking about the basics. Individual details related to various electrolytes and various abnormalities will be taking up in the subsequent sections. I don't know about you people, but I used to be really bad in fluid and electrolyte imbalance. If you look at the NEET super specialty papers, you will find questions being asked from this topic. But in Central Institute super specialty exams, these are considered to be rank deciders. And irrespective of entrance exam, this topic, these measurements, they will be useful for you even in your residency. So let us begin with the discussion. First of all, we'll be talking about basics, and in basics, the first thing we'll be considering is total body water. Now, total body water in a person, in a child, in a patient, it is always calculated according to what percentage does it constitute out of the total weight of that person. That is how we define total body water. We know that human body, we generally say human body is 60 to 70% water, but that is true for adults. If you look at this graph, let us not talk about this graph. This is the one we will be talking about. Baki ki baat we'll talk later. So total body water, this is, let me explain the graph. On the x-axis, you have the age mentioned. This is birth, this is prenatal life, this is the postnatal life, right? And on the y-axis, you have percentage body weight. Total body water always expressed as percentage body weight, right? So if you see that in the intrauterine life before birth, total body water contributes to as high as 75 to 90% of the total body weight. So if a fetus, suppose uska weight agar 1 kg hai, so 900 grams out of 1 kg will be water. Only 100 grams will be actual tissues in that baby. As period of gestation advances, this percentage total body water tends to come down. So the thing to remember here is, what is the percentage when birth happens? In a normal term baby, it is between 75 to 80%. So as you can see here, this is the point, it is between 70 and 80. So 75 to 80% is the value of total body water in a term child at birth. Then over the next few months till 1 year of age, there is a consistent fall in the total body water. But after 1 year of age, it relatively becomes a plateau and remains virtually same till puberty. Once puberty begins, you find that males will have more total body water compared to females. Now, what is the implication of this? What are the reasons of this? Let us try to write it down and understand why all this thing is happening. So, the key things to remember, first of all, in a fetus, total body water contributes to about 75 to 90% of the total body weight. Total body weight, not water. At birth, in a term child, in a term baby, the total body water is about, some books say 70%, some say 75%, some say 75 to 80%. So we generally take a value of between 70 to 80%, right? This is the general consensus if you look at other books along with Nelson. So total body water is 70 to 80% of the body weight. Total body water is 70 to 80%. It further falls as age advances, so that by 1 year of age, the total body water is about 60 to 65% of the body weight. But then from 1 year till about 10 to 11 years of age, it remains consistent. It remains same. So 60 to 65%, right? Once puberty begins, as puberty begins, you find that males, what are the changes which happen? If you remember, males tend to develop more muscle mass, and muscles are found to have higher total body water. They have a higher water content, and so males will have a more percentage of higher total body water, which will be about 60 to 65. You can remember a single value as 60%. Whereas in case of females, the muscle mass is relatively less, but they have a higher fat content. All this fat deposition will be happening in the breast and in the thighs and buttock area. Muscle mass is lesser as compared to males, and fats have a low water content. And so they will have a total body water which will be lesser, it will be about 50 to 55% will be the total body water in case of females. So this is the percentages, these are the various trends that you need to remember. So obviously the question arises ki why the total body water tends to fall as age advances. The simple reason for that is the muscle building up of proteins, building up of cells, cellular growth leads to fall in the total body water. Overall water may be rising, but as a percentage of the body weight, its percentage tends to fall. And this is the pattern that you need to remember. There can also be a practical implication of this. Let me give you an example. Suppose you have two children in front of you. One is a obese child and one is a normal child. So out of the two, which will have a higher total body water content? So your first tendency will be to think that the child is obese, he has more weight, so he will have more total body water. No, total body water is not measured as absolute number, it is always measured as a percentage of the body weight. A child who is obese will have more fat content. When a child has more fat content, remember that fat will contribute to weight, but fat is poor in water content. And so in an obese child, the total body water content will be less compared to a normal child who is having less fat content. Very useful concept, can be asked to you in entrance exam. So you can write it as a one-liner, potential one-liner, that in an obese child, the total body water content is less compared to a non-obese child. And the reason for this is fat has a low overall water content. Understood? So this is the first thing that you need to know. Let us move further. When we talk about fluid compartments, we have talked about total body water. If you look at fluid compartments, the water which is present can broadly be divided into two parts. This total body water can either be inside the cells, which is called as intracellular fluid, the fluid which is present inside the cell, right? And it can be outside the cell, that is extracellular fluid. So logical hai, total body water, some of it will be inside the cell, some of them will be outside the cell. Now what are the changes happening here? Let us go back to the graph which we had discussed and try to understand. Now forget about the upper total body water, uski baat ho gaya. Let us look at what is happening in ICF and ECF. Both are together constituting total body water, right? In a fetus, you will find that the amount of extracellular fluid is more than amount of intracellular fluid, right? As age advances, the number of cells rise. Because number of cells are rising, so fluid inside the cell will also rise, so its percentage contribution will rise. However, the contribution of ECF will tend to fall. At birth, ECF will still be greater than ICF, but around 3 to 4 months of age, this point, you will find that they will become same. ICF will be equal to ECF at around 3 to 4 months of age, which is a MCQ point already asked in Fellowship National Board exam. And post that, you will find that ICF will exceed the extracellular fluid, right? And again, very similar pattern will be seen. Extracellular fluid will be, almost same in male and female, whereas ICF will be more in males compared to female. For the simple reason, males have more muscle mass and so they will have higher water content, so ICF will be slightly more in males compared to females. So let us try to understand this. MCQ facts to remember. In utero, ECF is greater than ICF. Between 3 to 4 months of postnatal life, ECF becomes equal to ICF. MCQ point asked 5 years back. Beyond that period, that is beyond 4 months of age, ICF will always be more than ECF. So if we talk about you and me, right now, the fluid inside my cell is more than the fluid outside the cell, which includes blood also. And adult ratio of ICF to ECF is obtained from 1 year of age onwards. So these are the 4 points which you need to remember based upon this interpretation. So coming back to the fluid compartments. So if total body water is 60 to 65% of the total body weight, ICF or intracellular fluid is about 30 to 40%. So post infancy, that is 1 year age onwards till adulthood, it remains the same. The percentage remains the same. ECF will, as for the two parts, it is about 20 to 25%. There is interstitial fluid which is 15% and plasma fluid is only 5%. So actually blood contribution is the least among the total body water content if you look at these various segments. So these are the fluid compartments that you need to know. So obviously the question arises, what maintains the normal equilibrium of fluid between intravascular and interstitial spaces, right? So cellular fluid की बात अभी नहीं करेंगे, we will be talking about the ECF now. Now if you broadly see, there are two forces which are involved in maintaining this balance. These forces act in opposite direction and balance out each other. One force is called as osmotic pressure, also called as osmotic gradient, and second is called as hydrostatic pressure or hydrostatic gradient. What constitutes osmotic pressure? Osmotic pressure has a tendency, it pulls the fluid inside the vessel, right? So inside the vessel it pulls the fluid, whereas hydrostatic pressure tends to push fluid outside the vessel into the interstitium. Potential MCQ. What constitutes osmotic pressure? The most important component which contributes to osmotic pressure is something you already know. It is due to serum proteins, that is serum albumin. Whereas the most important thing responsible for hydrostatic pressure is the cardiac systolic activity, the flow of the blood combined along with forward flow of the blood. Combination of these two, especially the cardiac activity, the forward systolic activity, is responsible for producing the hydrostatic pressure. Normally, osmotic and hydrostatic pressure, they tend to balance out each other in general. In the end of the arteries, arterial end, you will find hydrostatic pressure being more dominant, and the venous end, you will find the osmotic pressure to be more dominant. So, at arterial end, usually it is found that the hydrostatic pressure exceeds the osmotic pressure, and so some fluid moves into the interstitium, right? Whereas at the venous end, the osmotic pressure will be more than the hydrostatic pressure, and so the fluid moves inside the vessel at this space, and there is a very constant balance which is produced. Overall, it is found that some fluid indeed moves into the interstitium. With this balanced fluid is returned back to the circulation by the presence of lymphatics. So lymphatics, among other roles, they also play a role in जो भी fluid बचा रह गया, whatever fluid is left outside into the interstitium, they bring it back. So these are the various processes which are happening. These are all basics that you need to know. You have read about them in your first year MBBS. You might have forgotten by that time. In NEET super specialty, there are questions related to basics and applied anatomy, physiology, embryology related to our pediatrics, and so these things are important. I am trying to make them as simple as possible, one-liners as possible. So what are the pathological states? What is happening in pathological states? So whenever you have a child with, let us take first possibility, child with low oncotic pressure. For example, hypoalbuminemia. What will happen in them? The oncotic pressure, since it is less, so the hydrostatic pressure will exceed the oncotic pressure, and so it will produce more fluid in the interstitium, producing edema in the patient, right? Second scenario is whenever a patient has congestive cardiac failure, a child has CCF. Whenever there will be CCF, there will be fluid retention happening in the patient. Sodium and water retention will be happening. Plus, due to compensation of CCF, the heart will try to increase the cardiac output. So there will be minor changes or minor increase in the cardiac output also, provided the patient is not in systolic failure, right? So the net result of this will be, again, hydrostatic pressure will be more than oncotic pressure, but it will not be due to fall in oncotic pressure, rather the hydrostatic pressure itself will be more majorly because of fluid retention, and so this will again produce fluid in interstitium producing edema. So whenever this balance between the two is disturbed, edema can happen. The causes of edema can be either low oncotic pressure or increased hydrostatic pressure. Net result, net feature is same, but pathophysiology involved is different. That is why you need to understand the differences, the balances between these two opposite forces. Now the third thing that we need to understand in basics is electrolyte composition. Now if you talk about inside the cell and outside the cell, let us make two compartments here, ICF inside the cell, or let's write it as ECF and ICF. So ECF will be outside the cell, ICF will be inside the cell, right? In ECF, the major cation is sodium, whereas in ICF, the major cation is potassium. In fact, Nelson says that the concentration of potassium inside the cell is 30 times the normal blood concentration. If you talk about major anion, in ECF the major anion is chloride, whereas in ICF the major anions are three. You have proteins, you have phosphates, and you have organic anions. Sometimes fourth one is also sometimes added, bicarbonate is as well. So these are the major cations and major anions between the two chambers that you already know. So this is the diagram which is given in Nelson. So you can see that in plasma the sodium content is 140, potassium is only 4, whereas inside potassium is 140 and sodium is only 13. Similarly, chloride and bicarbonate are the predominant anions outside. Inside you have the phosphate, proteins, some amount of bicarbonate, and chloride is minimal, which is present inside these. So these are the relative composition states that you need to remember. What is the implication of these different concentration of electrolytes across the spaces? The implication is very simple. The serum value of various electrolytes is not always reflective of true electrolyte content. There may be changes between the two. Sometimes there may be alterations of the true electrolyte content, what we call as the total body electrolyte content. This is especially true in cases of cations like potassium, because potassium is present outside the cell in minimal amount. Sometimes there may be movement of potassium inside and outside in various pathological states. And so the serum potassium measurement that we do, it is not always reflective of the true electrolyte content. In fact, calcium in the blood is very little, but most of the calcium is trapped in the bones. So implication means you cannot always rely on the serum values of these electrolytes to know about the true status. And there is a potential MCQ point which is given in Nelson. Nelson gives an example and says that in diabetic ketoacidosis, significant potassium depletion is masked by a transmembranous shift of potassium from the ICF to the ECF, from inside to outside. You know that insulin is required for the insulin pushes, especially in the presence of glucose, it pushes the potassium inside the cell. That is how it acts in case of hyperkalemia. In diabetic ketoacidosis, there is high blood glucose, but there is complete insulin deficiency, and so the potassium moves from inside the cell to the outside. So when you do potassium, you may find that the potassium content is relatively preserved. However, the total body potassium is lowered, and it can be dangerous in the later stages of diabetic ketoacidosis. They have given an example to signify that you cannot always rely upon the electrolyte contents. So what we have discussed so far, we have talked about the total body water, ICF, ECF, relative percentages, various ages, and which content is more inside, which content is more outside. Let us now move our attention. We are gradually building it up. These are all easy contents. Let us now focus our attention to slightly more tricky thing. Let us talk about osmolarity and what are the formulas, numericals that can be asked based upon that. Next, we discuss some points regarding osmolality. What exactly is osmolality? It is expressed in units of milliosmoles per kg. Osmolality refers to the solute concentration of a fluid. How many solutes are present in a fluid? That is what you call as osmolality. So, normally it is seen that ECF and ICF, they mostly stay in osmotic equilibrium. That is, ECF osmolality usually in physiological conditions, it equals the ICF osmolality, and the major reason for that is, although the concentration of ions is different across the two fluid spaces, the water tends to move freely across the two spaces, and so in normal physiological condition there is a osmotic equilibrium which is seen in most of the individuals. If there is a change in the ions, it will produce alterations in the movement of water, and this equilibrium will be balanced. So the normal plasma osmolality is kept within a very strong range of 285 to 295 milliosmoles per kg, can be a fact-based thing for your entrance exam. There is also a formula to calculate plasma osmolality depending upon the concentration of various solutes. It is seen that for all practical purposes, there are three solutes which are important, which contribute to the osmolality mainly. One is your sodium, second is glucose, and third is blood urea nitrogen or simply urea. So the formula says osmolality of plasma is given by the formula 2 multiplied by concentration of sodium plus concentration of glucose divided by 18 plus concentration of BUN, blood urea nitrogen, divided by 2.8. Why are we using 2 into sodium? Because sodium will never stay alone. Sodium will be associated with either chloride or bicarbonate. So we always take whatever sodium concentration, we multiply it by 2 to calculate the effective osmolality, to calculate the plasma osmolality. Similarly, glucose and BUN are usually mentioned in milligram per deciliter, but sodium is in millimole per liter. To convert that, we divide glucose by 18 and divide BUN by 2.8. This is the formula on which MCQ can be asked, a numerical MCQ can be asked in entrance exam. So please remember the formula. And it is found that the calculated osmolality, what you calculate by this formula, is actually lower than the actual measured osmolality, but it is within 10 milliosmoles per kg. Why it is less? Because there are other solutes which are available which are not a part of this formula. So contribution of those solutes will not be reflected, and so actual measured osmolality, measured and actual same hota hai, will be different from the calculated formula wala osmolality, and the gap between the two will be less than, in normal persons, less than 10 milliosmoles per kg. So there is a concept which comes called as osmolar gap. What exactly is osmolar gap? Osmolar gap is said to be there if the gap between measured osmolality, which is the actual osmolality, and calculated osmolality, which is calculated using the formula, is more than 10 milliosmoles per kg. So if the value is more than 10 milliosmoles per kg, we say osmolar gap persists. What are the substances which can lead to osmolar gap? So osmolar gap can be due to the following substances. It can occur due to ethanol. It can occur due to methyl alcohol. It can occur due to ethylene glycol. And Nelson says that calculation of osmolar gap gives us a clue in poisonings caused by methyl alcohol and ethylene glycol. It can also be seen due to excess sorbitol consumption. It can occur due to excess sucrose consumption in some of the metabolic disorders, and it can also be seen due to mannitol. When mannitol is given for Management of raised ICP, it can produce a elevated osmolar gap. That is how mannitol actually exerts its action, among other things. So these are the substances which can produce an osmolar gap, and it can be a potential MCQ. Now, what is the concept of effective osmolality? So एक तो था actual osmolality which you measure, we call it as measured osmolality. Second was what you calculated using a formula. Third is effective osmolality. There are plasma has many ineffective osmoles. Why they are ineffective osmoles? There are basically the major ineffective osmole example of that is urea. In addition, if the concentration is high, ethanol is also considered to be an ineffective osmole. The reason for that is very simple. These solutes, they do contribute to osmolality, but they freely move across the plasma membrane. And since they freely move across the plasma membrane, they do not determine the guiding force for the movement of fluid. So they are also called as ineffective osmoles. So there is a term which has been devised which you call as effective osmolality. Effective osmolality is found to be a better indicator of movement of fluid, to predict movement of fluid, than what formula we discussed. It is also called as tonicity of a fluid. So what is the formula for that? Effective osmolality is given by the formula 2 multiplied by a concentration of sodium plus concentration of glucose divided by 18. So the formula is same, but we have removed urea from that. If you remove urea from the formula of plasma osmolality, that becomes the formula for effective osmolality. So 3 osmolality terms you must be clear about. One is actual osmolality, which you calculate, which you measure. Second is formula based for plasma osmolality, which includes sodium, BUN and glucose. And third is effective osmolality or tonicity, which is the actual force which makes fluid move from one space to another. And this effective osmolality or tonicity determines the osmotic force, as I said, that is mediating the shift of water between ECF and between the ICF. So after these complicated, dull concepts, let us move our attention towards something more interesting, the practical application of these in clinical scenarios. So let's take a case. There was a patient of hyperglycemia who was found to have hyponatremia despite normal total body sodium. Explain how it can happen. It can easily be explained based upon the concept of effective osmolality. Now you know that whenever there will be hyperglycemia, because of hyperglycemia, there will be increase in the effective osmolality. When there will be increased blood, hyperglycemia kahan hai? In the blood. So there will be increased effective osmolality in the ECF, right? This will cause movement of water from ICF to ECF. Now there is more water in the extracellular fluid. This will produce dilutional hyponatremia. And so when you calculate the sodium level using the normal routine laboratory tests, you will find the sodium level to be low despite the total body sodium to be normal. So what is the way out here? In these patients, the measurement of serum sodium is faulty, and so we use another index for calculation of actual sodium content. It is called as calculated sodium value. The formula looks something like this. Corrected sodium in patients who are having hyperglycemia, we always calculate corrected sodium. Corrected sodium is given by the formula measured sodium, what came from the lab result, plus 1.6 multiplied by the difference between glucose kitna hai, -100, and the whole formula divided by 100. This is the formula for corrected sodium. It's a tricky one, but all you need to do is cram it up. And in patients of hyperglycemia, it is the corrected sodium which is taken to indicate the actual sodium content. This is more accurate indicator of the effective circulating plasma volume and osmolality than the simple measured sodium, serum sodium that you do on lab examination. And so we come to the regulation of plasma osmolality. Regulation of plasma osmolality is majorly done by the hypothalamic system. Now imagine a scenario. Do you know that normal plasma osmolality is, the normal value is 285 to 295 milliosmoles per kg, right? Imagine the first scenario. So suppose there is increase in the plasma osmolarity, concentrate हो गया है. So what will happen? Whenever there will be increase in plasma osmolality, there will be activation of two things. Both of the things will be happening in hypothalamus. First of all, there will be activation of osmoreceptors in anterior hypothalamus which control antidiuretic hormone synthesis. These osmoreceptors will stimulate the supraoptic and paraventricular nuclei in the hypothalamus to produce the hormone called as ADH, also called as vasopressin, antidiuretic hormone. This ADH will be released from the pituitary gland. So pituitary only acts as releasing area. Secretion formation occurs in the hypothalamus, right? This ADH, it will reach the renal tubules, and in the renal collecting duct, it will act on V2 receptors and cause insertion of water channels called as aquaporin 2. Due to the insertion of this aquaporin 2 channels into the collecting duct, there will be increased free water reabsorption, which will balance out the plasma osmolality in the patient. In addition, there are separate set of osmoreceptors which are present in hypothalamus which control the thirst center. They will cause increased thirst. This increased thirst will lead to increased water content in the plasma. More water content will happen because of drinking more water, and the net result will be there will be restoration. The plasma osmolarity will be normalized. So the most important thing involved in plasma osmolality is antidiuretic hormone, followed by the role of thirst in these patients. And it does not follow a all or none phenomena. It is a graded phenomena. Graded means in case there will be progressive rise in plasma osmolality, there will be progressive rise in the antidiuretic hormone synthesis. Likewise, there will be fall in plasma osmolality, there will be a progressive fall in ADH secretion. So obviously, when the plasma osmolality will be low, you will have relatively lower levels of ADH being produced. Next concept is effective intravascular volume. This is different from the true intravascular volume that we calculate. So what is the concept of effective intravascular volume? It is the volume status in an individual that is sensed by the body's regulatory mechanisms. And when we say body's regulatory mechanisms, we mainly mean the regulatory mechanisms which are involved in kidneys. What is the practical implication of this effective intravascular volume? You will find that in CCF, there is found to be volume overload. So when there is volume overload, there should not be any sodium retention happening. But still kidneys perform sodium retention. Why is it so? It is because that although in CCF there is volume overload, but the cardiac function is reduced. But there is a reduction in the overall cardiac function, resulting in decreased effective perfusion. There is decreased effective perfusion relatively of various organ systems, especially kidneys. Since these are the body's regulatory mechanisms, they perceive volume as low despite there being a overall overload. So they perceive the volume as low, and because they perceive the volume as low, they will regulate, there will be activation of renin-angiotensin-aldosterone axis, leading to sodium conservation or sodium retention in these patients. That is why despite volume overload being there in CCF, these patients are found to have sodium retention happening. This is the practical implication that we see. So how is the control of intravascular volume actually done? Control of intravascular volume closely mirrors that of serum sodium. right? So serum sodium and intravascular volume usually go hand in hand. So imagine a scenario where there is a reduction in the effective intravascular volume, right? There is a reduction in the effective intravascular volume. If it reduces, what will happen? When there is a decrease in the effective intravascular volume, it will be sensed by the juxtaglomerular apparatus. Particularly, there are sensors which are present in the afferent arterioles of the kidney, which will sense that there is fall in the renal perfusion. They will sense this fall in the renal perfusion and send stimulus to the renin-angiotensin system, to the juxtaglomerular apparatus, to produce more renin. This increased renin will produce first of all angiotensin 1 and then it will produce angiotensin 2. This angiotensin 2, it will directly act at the kidney and increase the sodium reabsorption, leading to sodium retention. Simultaneously, it will produce vasoconstriction, which will try to maintain the GFR in the patient, and it will also produce increased amount of aldosterone. You know that aldosterone causes sodium retention and potassium excretion. And so the net result will be increase in the sodium reabsorption. This increased sodium reabsorption will cause sodium and water retention, leading to improvement in intravascular volume. Right? So the renin-angiotensin system plays a very critical role in these patients. Now imagine a scenario where the reverse happens. Suppose there is increase in the effective intravascular volume. So what will happen now? If there is increase in the effective intravascular volume, there will be more blood will be reaching the right atrium. It will be reaching the atria, right as well as left atria. It will cause atrial distension. And atrial distension will lead to the release of peptides called as ANP, atrial natriuretic peptide. The name itself is saying natri means sodium, uretic means in the urine. So atrial natriuretic peptide will act on the medullary part of collecting duct and it will act to increase the sodium loss in urine. So it will reduce the total body sodium, reduce the plasma sodium or serum sodium, causing relative reduction in the intravascular volume. So there is a delicate balance which exists. This is a very simplified version we are talking about. There is a role of other regulatory processes. There is a role of BP sensing apparatuses involving the baroreceptors mechanism as well. But from entrance point of view, to keep it simple, these are the processes that you need to remember. They will be relevant in all the other systems, particularly endocrinology and the individual disorders that we'll be discussing in the subsequent modules. So, because we have talked a lot of relatively unrelated points, although they all are concepts in their own thing, so it is important to consolidate all of them at one place. So let us first talk about some facts for MCQs and then I will try to consolidate all things at one place, the information that you need to remember. So facts for MCQ, first of all, they can ask you normal plasma osmolality. It is between 285 to 295 milliosmoles per kg. The minimum urine osmolality is 30 to 50 milliosmoles per kg and the maximum urine osmolality is 1200 milliosmoles per kg. Urine cannot be concentrated beyond this point. And normally the kidneys excrete less than 1% of the sodium which is filtered at glomerular. So that is how efficient the kidneys are in preserving sodium. So what are the key points and basics from this module, this dry drab module, no images, nothing, but important in its own sense that you need to remember. First, total body water decreases with age in infancy, right? Then stays constant till puberty, only to fall slightly afterwards, and throughout adult life it remains normal. Males have a higher total body water than females. Reason being, males have more muscle mass than females. Obese children have less total body water than non-obese children because obese children have more fat. Fat has poor water content, and so their total body water content as a percentage of their body weight is less compared to non-obese children. Effective osmolality and not plasma or osmolality. It is the effective osmolality which guides fluid movement between ICF and ECF. Okay, so this movement is guided by effective osmolality, which is also called as tonicity. And not written here, but you already know that there are formulas for osmolality. Plasma osmolality is, there is a standard formula. Then we have measured osmolality will be slightly more than the calculated osmolality, and effective osmolality formula will not have blood urea nitrogen in that. Then in hyperglycemia, corrected sodium is a better indicator than measured sodium in these individuals. Osmolality control involves the release of antidiuretic hormone synthesis. Intravascular volume control involves sodium level, involves renin-angiotensin system, and also involves release of atrial natriuretic peptide. And whenever you have to strike a balance between osmolality and intravascular volume, Nelson says control of effective intravascular volume is more important than the control of osmolality in case the body needs to take precedence of one over the other. This is a point which is mentioned at 2 to 3 places in Nelson, and so can just be asked as a standard one-liner that in various pathological states where you cannot strike a balance between osmolality and intravascular volume, for body, effective intravascular volume is more important than any other thing. So this finishes our module of basics. In the next module, I'll be focusing on the individual disorders, and I'll first be starting with sodium. Thank you.